Good afternoon, everyone. So I will be speaking upon what's the role of compatible pair and what's the effect of compatible pair in kidney exchange. Actually, sometimes it becomes difficult for me to speak in front of varied people. Some are nephrologists, some are liver transplant surgeons, and some are policymakers. So I just will try to make it in a way that even every people should try to gather what actually I want to show. So we will start with simple scenarios. Upper one we can see O is the donor and A is the recipient. So it's straight, there is no issue. Lower down again we see A is the donor and B is the recipient. Again we can go ahead with ABO incompatible. So if these two patient pair and recipient pair are coming to me, directly I can go with the transplant, no problem. But then what if I say that the upper patient is having the HLA match of 0/12 and the lower patient I counseled him and he is saying that I am having fear of infection and so I don't want to go for plasma and all or go for ABO incompatible. So the scenario just changes, but look what's simple is in this scenario is that here it's so simple. This patient can give it to the other one and this patient can give it to. So here the problem for both of them is solved by just simple two-way exchange. So here the upper one we can say that the patient was a compatible pair. He could have gone for transplant without any problem. He was not having a DSA and all. Just because of he was having a low HLA match was poor, we just asked him whether you want to wait for some time or not. He was filling and he get a better match. Now he's getting 6/12 match, and the other patient, that patient instead of ABO incompatible is now going for ABO compatible transplant. This is the beauty of the compatible pair in kidney exchange. Second scenario again, B to B and O to B. Again here we can see the both of the patients are compatible. Okay, they both can go ahead with the transplantation. There is no incompatibility in blood group. But now the upper patient, the donor is 50-year-old and the recipient is 25-year-old. So there is a mismatch in age, and this patient 25-year-old will be obviously he needs a better life. He will be living more than 50, at least 25 years. But we know that graft survival is not more than 10 to 15 years of age for a typical, if I want to say. So the donor is older. The second one, the donor is 25-year-old and his recipient is quite old, and even the HLA match is 1/12 only. So what we can do, again we can do swap here. And now what? The younger donor is getting to the younger recipient and that upper donor is getting to the lower donor. Again the both compatible pairs were there, but still we are getting a better outcome. At least theoretically we are getting a better match, theoretically we are getting a better age donor. So this is the power of compatible pairs in kidney exchanges. So what are the parameters for a good outcome in kidney transplant beyond blood group and DSA? Because ABO incompatibility, other than that HLA incompatibility, these are the two. So this is a beautiful model created by Massey and Dory sir, and here we can see they have highly emphasized on younger age, male sex of the donor, then no hypertension in the donor, and the non-obese, and in the last one good HLA match. And here we can see HLA-B and HLA-DR, these two parameters they have taken into account. Obviously there are more HLA, and now someone I have seen were very much interested in epitope matching and all. Definitely it's there, but the role exactly how to do practical, how it will be implemented in a KPD softwares and all, it will take, I think, a little bit of time. So this is again the same from the same software. Here we can see the better the matches of the donor, the better will be the outcome in the recipients. So this is the basic crux of the compatible pairs. We are trying to find out better HLA match in them. We are trying to find out age mismatches that should be clarified. So this is the paper which found out that what were the motivations of compatible pairs which entered in paired kidney exchange. The reasons for entry of compatible pair was mostly HLA, better HLA match, then younger donor, mismatch in the kidney sizes, and even for low level of DSA, some people try to avoid it, and to avoid complex anatomy. 15 pairs reported the motivation was altruistic rather than based on recipient benefit. Again, this is not applicable to Indian settings because here altruistic donation is not. These were the hard endpoints of that paper. In fact, this is the only paper I found out in which exclusively clarified about the compatible pairs in kidney exchange. So when it comes to hard points, both the outcomes in terms of graft failure and mortality were similar in both compatible pairs as well as the original pair that would have been transplanted. So in Indian settings, if we see there's large burden of ESKD and large number of transplants we needed, which we are talking about from the day one and the start of the sessions also. So there's something which is very different from India when we compare to the Western world, is that the leading cause of mortality and graft loss and everything is because of the infection. Almost even if we try to go for a ABO incompatible transplant, even after rituximab and plasma exchange, even in clinical practice we have often get to find infection very common. So this is the cause of mortality and graft loss, poor outcome in Indian settings mostly. And again, medical expense in LMIC regions. This is our paper which we published, which described the multicentric experience of our KPD exchange. Here we can see how many exchanges we have done from 10-way to 2-way to, obviously we have to start with the 2-way, then progressively we have increased to other higher forms of KPD exchanges. Here the compatible pairs were almost not more than 7.5%, but still it's a huge number, 7.5%. But here we can see the sensitization is less, almost 6% only, and most of the reasons for joining KPD in our setups, in our multi-center study was ABO incompatible. So here we can see how this infection as well as the medical expense comes into play, which is different from that high middle income countries. So this was the further description, how many centers collaborated and how much were the kidney exchanges performed in all the centers. And now I just wanted to highlight here how compatible pairs were engaged in our particular center, IKDRC. Here we can see from 2012 to 2023, we can see the number of compatible pairs which were incorporated in the kidney pool exchange. So this is the higher magnifying lens I can see, I want to show here is that if we see green ones are the compatible recipients and yellow ones are the ABO incompatible and red ones are the sensitized. So the first 1 and 4, if you see, I'll just take 2 minutes more. First and 4 we can see even the sensitized patient have benefited by entering of these compatible pairs. And not only 2-way exchanges, we got 3, 4 and 1 5 exchanges. The last one was the 6-way exchanges formed from the compatible pair. So this is the beauty again of this compatible pair entry in the kidney pair exchange. The outcomes we found out there was no difference in the outcome except in the median age, but again the age in the Indian cohorts are mostly in the 45s. The impact of CP entry, again, even we are getting compatible pair which is having a O donor, it will just changes the whole scenario. We will be getting a better match and better chain, and even elongated chain can be possible, complete chain can be possible, but we are getting a donor O. One more thing which I want to highlight, that this compatible pair which we are engaging in our exchanges are mostly doing well. So that we have to take care that the recipients are doing well when we are asking them for a compatible pair entry. This is the outcome. There was no difference in the outcome in our study, compatible versus incompatible, both in terms of graft loss and mortality. These are some way we can improve the outcomes, and we can ask more and more people to go for the compatible pool. But again, this will be a hurdle, and especially only in setups which are having huge volume in the kidney transplantation, only in those centers which will be possible for compatible pair. The transplantation program which we started in some small centers is very difficult for to entry this compatible pair. Again, we have to do the national KPD exchange and all those things. Then only this compatible pool can be expanded. That's all. Thank you.